continue with the family Flaviviridae, and we are going to study one of the most important in Vietnam, the dengue virus, family Flaviviridae. And later, the second part of the class is about some viruses that cause typical diseases in children. We don't have time to explain this. So we are going to say very few things, very few. We'll talk about measles, mumps, and rubella. But in the class, we just review some things, okay? So, before we start, I want to tell you something about the last class. When we were talking about hepatitis, viral hepatitis, I remember that one of the students in this class asked me a question about the transplacental transmission of hepatitis E virus. And I said that to my knowledge, I didn't know anything and that I didn't know if that was possible or not. I was checking and it seems that the transplacental transmission from the mother to the fetus of hepatitis E virus is possible, but very, very uncommon. But I think when I was reviewing, I think some cases have been reported, but very, very few. And to my knowledge, I have no idea about the problems that the fetus has. I don't know about that. But I remember that one of the students asked me that question, and I want to explain today, okay? I don't know if the student is now connected or not. Are you there? The student that asked me last week about hepatitis E virus transmission transplacentally?
Yes.
Okay. If I remember, and in the complements for better understanding, I explained that I don't know, or very few people know about that, but it's possible, but very, very uncommon. The only thing that you have to remember about the transmission of hepatitis E virus is that it's transmitted through the fecal oral route, but transplacental transmission may be possible. Okay, so lesson 15. So where we are, look, we are here. We are going to study dengue virus. Dengue virus belongs to the family Flaviviridae that you already know because hepatitis C virus also belongs to this family. Before we start with dengue, we have to introduce a new concept because you don't know yet, because you haven't studied epidemiology yet. So we are going to introduce the concept of arboviral disease and zoonotic viruses before that. So what about zoonotic viruses? Many viruses are zoonotic, a lot, and growing and growing. Remember, zoonotic transmitted from animals to humans. Many RNA virus families are zoonotic, a lot. Zoonotic viruses may be classified, divided into two groups. Arboviruses, that means arthropod-borne viruses, so viruses transmitted by arthropods, and non-arthropod-borne zoonotic viruses. So we have two types. Joder, con la waiting room. Wait a moment, please, because with the waiting room, I have to admit one by one, and this is annoying for me. Wait a moment. Okay, so zoonotic viruses, we can divide into two groups. No, sorry. Here. No, this is not what I want to show you. For a moment. So, arboviruses means viruses transmitted by arthropods, arthropod-borne viruses. Arthropods are a lot. Mosquitoes are the most common. Okay, so we are going to focus now in arboviruses, okay? Because non-arthropod-borne zoonotic viruses are so many. You know some. For example, the new coronavirus or hepatitis E virus. They are zoonotic viruses not transmitted by arthropods. In this class, we focus in arthropod-borne viruses here. So look, when we talk about diseases caused by arboviruses, we have to consider three organisms. we have to consider the virus. We have to consider the host. And we have to consider the vector. Remember the concept of vector. Vector is the animal, in this case, the arthropod, that transmits the disease from one host to another. So 3 organisms: virus, host, and vector. What about the hosts? The hosts are usually vertebrate animals. And we can differentiate 2 types of hosts: the natural hosts and the dead-end hosts. Again, wait one moment, please. We have to disable the waiting room, because if not, this is annoying. So, wait a moment. Okay, so natural hosts and dead-end hosts. Who is the natural host of the disease? Well, the natural host is the usual host. Is the host that usually suffers the disease. They suffer the disease, of course. And these natural hosts are usually animals. These animals may be birds or small mammals. And these natural hosts, when they are infected, when they suffer the disease, they suffer a high viremia. That means if they suffer a high viremia, the spread, the transmission of the disease is very easy. What is a dead-end host? Dead-end does not mean that the host will die. No. Dead-end means that they are the last host and they cannot transmit the disease. That's the meaning of dead-end host. Dead-end hosts are non-usual hosts. So they don't usually suffer the disease. They suffer the disease, and sometimes very severe, the same as the natural hosts, but it's not usual for them. These dead-end hosts are usually humans, usually. And these dead-end hosts cannot transmit the disease to others because they don't develop a high viremia, so low viremia. So the spread is not possible. Do you understand the difference between this and this?
Yes.
Anyone has any question about this? Do you understand why hosts with high viremia can transmit the disease and hosts with low viremia cannot? Any question about that?
Can you explain again?
Yes, the disease is transmitted from one host to another host. In the middle, there is a vector. This vector is usually a mosquito. The mosquito bites one host, takes the blood, and then bites another host. So when the vector bites and feeds on the first host, the vector is going to take the virus from the blood. If viremia is very high, the vector will take the virus very easily. If viremia is very low, the vector cannot take the virus. You understand?
Yes.
You understand, yes or no? Any question?
Yes, but what if a kind of mosquitoes bite the low viremia patient and then transfer it?
Mosquitoes, if the for the mosquito to become infected, they need to take a lot of viruses. If not, the probability is very low, very, very low. Okay, so we have 2 exceptions. We have 2 exceptions for this rule when we talk about dead-end hosts. For two diseases, exceptions to this rule. For 2 diseases, very important for humans, dengue and yellow fever. For these diseases, humans are also natural hosts, not dead-end hosts. So humans can't transmit the disease. And these two exceptions are very important. Today, we are going to study dengue. Tomorrow, we are going to study yellow fever. These are the most important exceptions. Okay, so this is about the host. What about the vectors? What about the vectors? The vectors, as I told you, they are arthropods. Usually mosquitoes, not always, but usually mosquitoes. And they don't suffer the disease. They spread the disease, but they don't suffer the disease. So what happens to them? They suffer infection, but not disease. They suffer a persistent, remember the meaning of persistent infection of the salivary glands. So this is the reason why they can transmit the disease. Sorry, wait one moment, because I have to close this window. Okay, so this is the difference. So they don't suffer the disease. They are infected, but not disease. So when we talk about our viral diseases, we have to consider three types of organisms: the virus, the host, and the vector, three organisms. Okay, so we go back to the presentation. And what about the, wait a moment. Sorry for this, but when we enable the waiting room, I have to admit you one by one. And those students that come late are very annoying to follow the class. So please start the class on time, okay? Because if not, I have to stop to enter in the waiting room and admit you. The class starts at 7, not at 7:20. Okay, so we continue. So what about the clinical findings? What about the clinical syndrome? Most arboviral infections are asymptomatic, most of them, fortunately, or they cause a very mild, non-specific disease. So most of them are nothing or very mild, fortunately. However, sometimes 3 possible clinical syndromes may appear. And for this, I always show a picture with a Venn diagram like this one. And here I show the 3 possible syndromes that may appear. And sometimes they are overlapped, sometimes. This is the reason why the study of these diseases is so difficult. For example, in green color, I read you here, infections of the clinical syndromes related with the central nervous system. So encephalitis. In blue color, hemorrhagic fevers. And in red color, a syndrome that we call fever arthalgia rash. And sometimes, as I show you in the picture, they are overlapped. So look, here in the middle, we have dengue. So dengue may be found sometimes as a fever arthalgia rash or hemorrhagic fever and or encephalitis. A lot of overlap of syndromes. Later, we will explain what's the most common. Encephalitis, only encephalitis, we have one very important in Vietnam that we will study tomorrow. It's called Japanese encephalitis virus. This is maybe the most common viral encephalitis in Vietnam. Hemorrhagic fevers, we have the most important, yellow fever, that we will study tomorrow. Here we have another encephalitis that we will study tomorrow, that sometimes may appear as a fever arthalgia rash, that is called the West Nile encephalitis. And here, only fever arthalgia rash. Maybe you don't remember, but 4 years ago, we have a very important epidemic in the world called Zika virus. This was very important 4 years ago, but maybe you forgot. And we have another one that is called, well, we have a lot. We have another, to mention only one, that is called chikungunya, that we are not going to study because we don't have time. So look, I show you here only some arboviral diseases, only some. Today, we are going to focus in dengue, because dengue is one of the most important viral diseases that we suffer in the country. Okay, so we go back to the presentation. This is the same that I showed you, okay? The same. Okay, so Flaviviridae, remember, Flaviviridae contains many viruses. The name Flavi comes from the Latin language that means yellow color. So look, the pathogenesis is difficult to understand. The pathogenesis of all flaviviral diseases is difficult to understand, but they have some things in common. So I'm going to make a kind of viral cycle, sorry, a kind of infectious cycle from exposure to disease in very simple words, okay? So for all flaviviral, arboviral diseases, so flaviviruses transmitted by arthropods, the pathogenesis is very similar. So we start with exposure. Exposure is through inoculation into the skin, usually mosquitoes, okay? So this is exposure. So the first step, well, the second step is infection of the skin. Infection in the skin. And some cells are infected in the skin. For example, dendritic cells that I hope that you remember from the second class. Monocytes, macrophages that I hope you remember from the second class. And some endothelial cells, and maybe others. So these cells may become infected. After that, the viruses or these cells go to the lymph nodes. And after that, well, in the lymph nodes, they can also replicate. After that, they go to the blood. That's called viremia. And when the virus is found in the blood, at this point, when viremia appears, the patient may show symptoms already, but these symptoms are non-specific. So fever, myalgia, fatigue, non-specific symptoms. Most arboviral diseases, most flaviviral arboviral diseases stop here. Most. Don't go further. So here, most flaviviral arboviral diseases are controlled. They don't go further. However, in some cases, not many, the virus can spread. The virus is in the blood, and sometimes it can spread. And they are going to try to find the target cell, the target host cell. This target host cell may be sometimes the same as this one in the skin, so monocytes, macrophages. Actually, these are the most important target host cell, monocytes, macrophages, the most important. Sometimes cells from the central nervous system, sometimes cells from the liver, sometimes cells from the skin again, and other sites. So after that, when the virus is replicating in the final target host cell, the specific syndromes may appear: hemorrhagic fever, or fever, arthralgia, rash, or encephalitis, or whatever. This is not microbiology, this is clinical medicine that you will study next year, okay? So look, so when we look at this infectious process, we can notice that two possible outcomes may appear. two possible outcomes. The most common, when the disease is controlled here, the most common outcome is non-specific symptoms, as I told you before. This is the most common outcome. However, if the target host cell is infected, a specific clinical syndrome may appear. This is the second outcome, okay? So look this. The most important target host cell infected is the monocyte macrophage. Remember from histology, monocytes and macrophages are the same cell, okay? Monocytes, when they appear in blood, macrophages, when they appear in the tissues. This is histology. So, don't forget this. The primary, the most important target host cell for arboviral flaviviruses are monocyte macrophages. And remember something that I told you 2 weeks ago. Monocyte macrophages are very important cells that belong to the immune system. 2 weeks ago, I told you, when a virus infects cells that belong to the immune system, we may have serious problems. And we are going to have serious problems when macrophages are infected, as you will see later. So we are going to start with dengue. Dengue comes from a Spanish word that appeared around 500–600 years ago that comes from another language. And this another language is called Swahili. And the meaning is this one that I show you here. It's like something weird that is caused by an evil spirit. It's very interesting. But anyway, this is not important. Only if you are interested. Epidemiology, introduction and epidemiology of dengue. Dengue is the most important arbovirus that infects humans currently. The most important. Around 2,500 million people are at risk of suffering dengue. It's the most quickly spreading arboviral disease in the world. What about the vector? The vector of dengue is Aedes mosquitoes that you will study next year perfectly. These mosquitoes are very common in Vietnam. In your house, you are going to find these mosquitoes every day. The most important vector is Aedes aegypti. This is the most important. However, in the last years, we have found other vectors. For example, Aedes albopictus. In Vietnam, we have both. Maybe Aedes aegypti is more common here. In my country, we don't have Aedes aegypti. In my country, we have Aedes albopictus. So Aedes mosquitoes, you will study next year. And look, as I told you before, this is one of the exceptions to the rule. For dengue, humans are the natural host. This is Aedes aegypti mosquito taking a blood meal. Aedes mosquitoes have these white things in the joints of the legs. You are going to find many in your house. This is the same, Aedes aegypti female. Next year, you are going to study in the practices of parasitology Aedes mosquitoes, and you are going to learn a lot because the practices of parasitology are very good. And you are going to learn so much about mosquitoes. This is Aedes albopictus, very similar. And here in this picture, you can compare. This is for next year, not for today, only to show you. In the last 60 years, dengue has spread a lot. So currently, we can consider dengue as a global pandemic. Almost every country between the tropics is affected. And we have outbreaks every year. The most important in Southeast Asia, here, but also in South America. In Asia, dengue is hyper-endemic. We have epidemics of dengue every year. For example, in Vietnam, the epidemic last year was terrible, was dramatic, was the most important. This year, it seems that it will be lower. So look, almost all countries between the tropics have dengue virus. So the temperature is very important. This picture is a little bit old, but it hasn't changed so much. The country with most cases of dengue is Brazil. The second one is Indonesia. And the third, Vietnam. So what about Aedes mosquitoes? This is for the next year, but I have to tell you something about them. Aedes mosquitoes are peridomestic. In Latin language, domestic means house, and peri means around. So Aedes mosquitoes live around the houses. They are usually found in water collections. This is the place where they put the eggs. They feed on humans, mainly by day, but not only. They most commonly feed at dusk, so in the evening, and at dawn, early in the morning. However, they can bite at any time of the day. So Aedes mosquitoes are very successful because they can bite and spread infection all year long and at any time of the day. Look, these are the two possible epidemiologic cycles of dengue. So in the jungles, in the forests, dengue is a disease of primates, like some monkeys, okay? So dengue virus is transmitted from monkey to monkey through the Aedes mosquito. Sometimes the Aedes mosquito may transmit the disease to the human. It's zoonotic, okay? And in the city, urban cycle in the city, humans can infect other humans through the bite of the mosquito. Because for dengue virus, humans are natural hosts. So in the beginning, dengue was zoonotic. Currently, dengue is transmitted from human to human. So look, remember, viremia, the amount of viremia is critical to the spread of the disease. Humans develop a lot of viremia. That is the reason why we can spread the disease. That is the reason why humans are natural hosts. The viremia lasts between 3 to 6 days since the beginning of the symptoms. The mosquito can transmit the disease between 8 to 12 days after feeding in the blood, okay? So when the mosquito feeds on the host, the mosquito needs a time around 8 to 12 days to be able to transmit the disease. That's called extrinsic incubation period, but that is not for today. This is for next year, okay? So the mosquito needs a time, oh, sorry, the virus needs a time inside the mosquito, okay? This time is between 8 to 12 days. Dengue virus, related to the mosquito, dengue virus, dengue infection is strongly correlated with the rainy season because during the rainy season, there is an important increase in the mosquito population. Look, in this picture I show you the cases of dengue in red color and the rain in blue color. So as you can see here, this is Cambodia, our neighbors. As we can see here, the cases of dengue are strongly related with the rain because during the rain, the population of mosquitoes increased very much. What about Vietnam? The information that you have in your presentation is not updated because the information that you have belongs to the last year. This information that I show you here is the information updated for this year. What about Vietnam? Until 1 month ago, this is the last information that we have in the World Health Organization, we had more than 20,000 cases. This is a lot. However, compared to the same period last year, this year we are much better. This year, the number of cases have decreased more than 50%. Last year, I don't know if you remember, but when I was teaching this class last year, I told the students that The epidemic of dengue last year in Vietnam was dramatic. This is the map provided by the World Health Organization from the BOIT in Vietnam. And in blue color here, you can see the number of cases of dengue in Vietnam last year. In green color, this line here is the number of cases this year, until here, until March. So this year, it seems that the number of cases in Vietnam has decreased a lot. And this is very good, because last year, the epidemic of dengue was dramatic. This year, it seems that we are much better. Okay, so microbiology. This is microbiology. And this is important. Dengue virus. There is an important genetic variability in dengue virus. And you must remember this. We can find 4 different serotypes of dengue. Type 1, type 2, type 3, and type 4. Dengue virus is a flavivirus. Remember the concept of quasi-species that we explained when we talk about hepatitis C virus. Quasi-species appear in the host because the mistakes that the RNA polymerase makes during replication, okay? The most important thing that you have to remember is that we have 4 serotypes of dengue. Type 1, type 2, type 3, and type 4. What about the immune response? Okay, so we have a problem because you don't know immunology. We always have this problem, but we are going to try to explain. To understand the pathogenesis of dengue, it's very important that we understand the immune response against dengue. Very, very important. If we don't understand immunology, we can't understand why dengue appears. So this is very important. The immune response against dengue is humoral, antibodies, and is also cellular, okay? Both. We are going to focus only in the humoral response, in antibodies, because this is strongly related with the severity of the disease. So before we continue, I will tell you that when the disease becomes severe, that is related with the immune response, with the humoral immune response. But this is difficult to understand because that also depends on the virus. I will try to explain. Antibodies. The infected host, the human, will produce antibodies against many different proteins, okay? Many different antigens that we are not going to study. Remember that the E protein in flaviviruses is the protein at the envelope that the virus uses for binding host cell receptors. Anyway, antibodies against many different antigens that we don't need to remember. So look, we are going to try to follow this. The primary infection, so the first time that we are infected, usually when we are babies, the first time provides long-lasting immunity against the same serotype that has infected our body. So for example, if we are infected by serotype number 3, we will develop antibodies against serotype number 3, and we will be protected against serotype number 3 forever, okay? We have 4 serotypes. Remember, sero comes from serum, okay, from antibodies. So when we are infected by one serotype, we will be protected forever against that specific serotype, okay? So if I tell you this, it seems that humans can only suffer 4 dengue diseases in their life, right? Do you understand that?
Yes.
Any question about that? That's very important.
What?
Can you say again the last sentence?
Sorry, which sentence?
The last.
Repeat.
Yes. Repeat the last.
We have 4 serotypes of dengue. Type 1, 2, 3, and 4. When we suffer dengue disease by one of them, for example, when we suffer the disease against serotype 3, we will produce antibodies against serotype 3. And these antibodies are going to protect us forever. So this is the reason why we can only suffer 4 dengue diseases in our life. Because dengue has 4 serotypes. Do you understand? Do you understand, yes or no?
Yes.
All the people can understand this? Oh, do you know something about this? I'm not really sure. Because silence means many different things.
Ở chúng ta có tới 4 tiếp virus dengue khác nhau, cho nên là khi mà một cái tiếp ban đầu nó nhiễm vào bên trong cơ thể của chúng ta thì nó sẽ kích thích cơ thể chúng ta sinh ra cái kháng thể, và cái kháng thể đó nó chỉ đặc hiệu với cái tiếp vừa mới nhiễm vào bên trong cơ thể của chúng ta thôi, và cái kháng thể đó nó sẽ tồn tại rất là bền vững và nó bảo vệ suốt đời đối với cái tiếp mà đã nhiễm vào bên trong cơ thể của chúng ta. Tuy nhiên ở những cái lần tiếp theo, nếu như mà chúng ta bị nhiễm bởi 3 tiếp còn lại thì cái kháng thể đó nó không đặc hiệu và nó sẽ không giúp cho chúng ta có thể bảo vệ được, và đặc biệt là ở cái lần nhiễm thứ hai thì cực kỳ nghiêm trọng đối với bệnh nhân, vì những cái cơ chế mà thầy sẽ giải thích sau cho các bạn.
Okay, so we can suffer dengue disease only 4 times. Actually, we don't suffer 4 times. We usually suffer 2 times or 3 by something that we are not going to explain. So, but 4 is the highest number of dengue diseases that we may suffer. So, when we are infected by one serotype, we will develop antibodies against that serotype forever, and we will be protected. But something very important. When we suffer a disease by one serotype, for example, against serotype 3, these antibodies against serotype 3, or whatever, can also protect the host against the other serotypes, but not forever, for less than 2 years. I repeat again. I will use the whiteboard. So, for example, if we are infected by serotype, I don't know, whatever, by serotype 4, okay? When we are infected by serotype 4, we will develop antibodies specific against serotype 4. And these specific antibodies are forever, or almost forever. So we are protected against serotype 4, against dengue virus type 4. So we will never suffer dengue virus type 4 again. However, these antibodies also protect against the other serotypes, type 1, 2, and 3, but not forever, just for less than 2 years. So when we suffer dengue disease, we will be protected against dengue disease for a period around 2 years or less, okay? After 2 years, these antibodies cannot protect us. After 2 years, we are susceptible, we may suffer dengue virus type 1 or 2 or 3. Do you understand this?
Yes.
Any question about this? We are going to explain in very simple words because you don't know immunology, okay? So we have to explain in very simple words. So remember this, these antibodies also protect against the other serotypes, but not forever. So what happens after 2 years? what happens after 2 years? After 2 years, we are susceptible again. And we can suffer dengue. But something else that is very important and it's very difficult to understand. After 2 years, we are susceptible, so we may suffer dengue again. And we have something very important here. So this is a secondary infection. Secondary means the second time. We may suffer dengue again, secondary infection. And this secondary infection, this may be much more severe than the first one. And this is the problem to understand. This is very important and you must remember. The second dengue infection that we suffer is usually more severe than the first one. And why is this possible? Why is this possible? Remember what I told you in the beginning. The most important target host cell are macrophages, monocytes, macrophages. Remember that. So what happens? Look here. This is an example. This is an example. This is the same example as I told you before, okay? Primary infection. In the beginning, the first infection that you suffer in your life, this happens when you are a baby. So imagine that you are infected by dengue virus type 1. What happens? Antibodies specific against dengue virus type 1 appear. So you are protected forever against dengue virus type 1, okay? What happens after 2 or 3 or 4 years? After 2 or 3 or 4 years, you are not protected against the other serotypes. So imagine that after 2, 3 or 4 years, you are infected by a different serotype. For example, serotype 2, okay? Look what happens. When you are infected by serotype 2, you already have antibodies against dengue, but not against serotype 2. You have antibodies against serotype 1, not against serotype 2. The problem is that antibodies against serotype 1 can also bind serotype 2, but not very well. They bind very bad. So they cannot stop the infection. They cannot control the disease because the binding is not good. And look, this is the macrophage. Remember from the lesson number 2 about immunology. I hope that some of you remember, I hope, when we were talking about antibodies. Macrophages have receptors in the cell membrane, and these receptors in the cell membrane bind the Fc fragment of the antibodies. So look, when these antibodies bind the serotype 2, but not very well, the Fc fragment binds the Fc receptor in the macrophage. So look, now the virus is very, very, very near to the macrophage. So the infection of the macrophage is very easy now. So look, when we have these antibodies, the infection of the target host cell, the macrophage, is very easy. So in secondary infections, the viral infection of the host cell is much easier. So secondary infections are usually more severe. This problem is called antibody-dependent enhancement. Do you understand this?
Yes.
Questions about this? Because in my experience in the last 6 years, I know that many students don't understand this. Questions?
So why is it in 2 years we have immune against other type of dengue?
When you suffer the secondary infection, you will be protected forever against serotype 2. So for 2 years, you will not suffer dengue, okay? After 2 years, you may suffer an infection by serotype 4 or serotype 3. So the highest, the maximum, the highest number of dengue diseases that we may suffer is 4, okay? However, people usually suffer 2 dengue infections or 3, because the 3rd and the 4th are very, very mild or even asymptomatic. So the most important dengue disease that we suffer is the 2nd one, because that's the most severe. Questions?
I mean, why is the limit is 2 years?
We don't know why 2 years, because after 2 years, the antibodies disappear. Sorry, the antibodies do not disappear. The antibodies cannot protect. The reason why is 2 years and no more, I don't know, or we don't know, because we know very little about neutralization of antibodies. The neutralization of dengue virus is not well understood. And to my knowledge, I don't know the reason. I don't know why it's 2 years and not 3 or not 1. I have no idea. And I think nobody knows.
Okay.
Questions?
Thank you.
Questions? This is very important to understand, because if we understand this mechanism, we understand why secondary infections are more severe. No questions? So we continue?
Teachers.
Yes.
So the AD is mean the antibody of the type 1 in the example.
Sorry, can you repeat again?
So the antibody dependent enhancement
Yes.
is either the antibody for the type 1 in the example.
This is an example. I show you here type 1 or 2 or 3 or 4, whatever. The first infection that we suffer may be by any serotype, type 4 or 2 or 3 or 1, whatever. In this example, I show you 1, but any.
So the AD is in the pictures is the same with the antibody for the type 1.
Sorry, I don't understand your question.
So can I ask the meaning of the antibody dependent enhancement?
The meaning.
Yes.
Do you understand enhancement? Increase.
No.
Increase. So, you have to translate these words before the class, okay? I remind you that. That is the reason why we give you this information in advance. Anyway, enhancement means increase. So increase that depends on the appearance of antibodies, okay? Do you understand?
Yes.
Increase. Enhancement in English means increase, something like that. So that means that the viral infection increases when antibodies already exist, okay? That is the meaning. More questions?
Do you know which is the most common in Vietnam?
No, I don't know. I think it's serotype 2, but I'm not sure. I was looking for that information. I was looking and I found many papers, and depends on the area. It's in the south and in the center and in the north, it's not the same. It depends on the area. I think serotype 2 is very common, but I think that's in the south, so I'm not sure. Sorry, but I don't know. I found many, but I don't know exactly which one is the most common in Da Nang. I have no idea. In Asia, in general, serotype 2 and 3 are the most common. But I was looking for that information many times, and I found many papers. But depending on the area, the serotype is one or another. So I'm not sure, sorry. More questions? No? Koi, do you want to say something about this?
Cô giải thích cho bạn một tí chỗ này với một số bạn không hiểu ha. Tức là khi mà các bạn bị nhiễm bởi cái tiếp virus ở đây, ví dụ thôi ha, là một cái virus D1 chẳng hạn, thì khi mà các bạn bị nhiễm bởi virus D1 thì cơ thể chúng ta nó sẽ sinh ra cái kháng thể đặc hiệu với virus D1 đó. Trong vòng 2 năm trở lại, nếu như các bạn nhiễm với các tiếp còn lại thì cái kháng thể đó nó có thể chống lại một cách đặc hiệu và loại bỏ được. Nhưng sau 2 năm thì có thể là có những cái biến đổi mà cái kháng thể nó sẽ không còn đặc hiệu để có thể diệt được các cái tiếp virus còn lại. Tuy nhiên thì sau 2 năm, khi mà các bạn bị nhiễm với một trong 3 tiếp còn lại là D1, D3, D4, D2, thì lúc này các cái kháng thể này nó sẽ gắn kết được với cái virus đó. Nhưng mà nó không trung hòa, không tiêu diệt được virus. Khi mà cái kháng thể nó đã gắn kết được với virus rồi thì cái cấu trúc Fc của virus là cái cấu trúc mà cố định đó các bạn. Nó lại là một cái cấu trúc mà có thể gắn kết đặc hiệu với cái receptor trên bề mặt của các cái macrophage mà các bạn biết là lúc nãy thầy nói là macrophage hay là monocyte là những cái tế bào mà virus nó nhiễm vào, và cái tế bào đặc hiệu này mà nó bị nhiễm vào thì nó sẽ gây ra các cái biểu hiện của triệu chứng đặc hiệu của bệnh. Thì khi mà cái kháng thể nó đã gắn được với virus thì cái Fc của kháng thể nó lại là một cái yếu tố đặc hiệu gắn được với cái receptor trên bề mặt của tế bào macrophage. Do đó cái virus nó sẽ được gắn liền gần với cái macrophage và tạo điều kiện cho nó có thể xâm nhập vào macrophage nhanh hơn. Cho nên người ta gọi đó là hiện tượng là tăng cường phụ thuộc vào kháng thể. Có nghĩa là có kháng thể sẵn rồi thì virus nó sẽ có được cái điều kiện rất là thuận lợi để nó xâm nhập vào trong macrophage và nó gây bệnh.
One thing, because I know, because you asked about this, so I repeat again. The first infection that we suffer, the primary infection, in this example that I show you here is type 1, but the first disease, the primary infection may be either serotype 1 or 2 or 3 or 4, okay? So the first infection is not always serotype 1, it depends, okay? Sometimes the type 1, sometimes the type 4, whatever. In this example, we show you here serotype 1, but any, okay? Okay, so we also develop a cellular response against dengue viruses, but we are not going to say anything about the cellular response. Remember, only interferon gamma. Interferon gamma is produced by T helper 1 cells. It's very important to fight intracellular infections. So I told you, people living in an endemic area, for example, Vietnam, can be infected with 3 or 4 dengue serotypes in the life. However, as I told you, the third and the fourth are not severe. So the most severe is always the second. More things related with pathogenesis, with damage. This damage depends on both the virus and the immune system. The most specific and dangerous life-threatening feature is plasma leakage. I hope that you know what is plasma leakage because I show you a video in the link, if I'm not mistaken. I hope you understand this because we are not going to explain it.
Teacher, we don't see this hormone.
Sorry?
We don't see the...
Yes, sorry. Yes, you are right. Sorry. So I repeat again. Sorry, the problem is my problem. So here, sorry, I repeat again because I wasn't sharing the screen. Okay. Okay. So I repeat again. So persons living in an endemic area like Vietnam may be infected with 3 or 4 serotypes in their life, not more. However, the third time and the fourth are not severe. The most severe is the second one. About the severity of the disease, why some diseases are very severe? What about the pathogenesis of the disease? This is not microbiology, this is clinical medicine, but I have to explain you a little. The most specific and dangerous life-threatening feature is plasma leakage. So, plasma is lost from the blood vessels because the endothelial cells are impaired. Endothelial cells of capillaries are damaged. And this damage of endothelial cells depends possibly on both on the virus, some antigens from the virus, and also on the immune response, possibly antibody. So this is, don't forget, this is one of the questions that I ask you in the quizzes. The plasma leakage is the most specific and life-threatening feature. This is the first one. And the second one is problems in hemostasis. These problems, this impairment in hemostasis may cause hemorrhagic fever, bleeding in some patients. So look, this is not microbiology, this is clinical medicine, but I have to tell you some words about dengue. The incubation period of dengue is usually 5 to 7 days, usually, but the range is from 3 to 14 days. Most dengue infections are very mild, subclinical. About 75% of them are very mild. Most infections in children younger than 15 years are asymptomatic or mild. However, the risk of severe dengue is higher in infants around 4 to 9 months, and also in children around 5 to 9 years. I ask you a question, and you have to answer the question in less than 1 minute because we don't have time. Why do you think infants 4 to 9 months of age may suffer a severe dengue disease? Why do you think that? This is one of the questions that I ask in the exams, but I prefer to ask you in the class.
Maybe because in children with 5 or 9 years, the immune system had developed.
No. That question comes later. Now I ask you in infants 4 to 9 months. So in very, very small children. Why?
Maybe because of the immune system had not developed completely.
Because the immune system has not developed completely. That's one of the reasons, but that's not the most important reason. The most important reason is anyone has any idea? I told you that severe diseases. Yes, tell me.
So I think the infants, they already have the antibodies.
Why?
And because of the mother, maybe they have the antibodies and they just speak to the infants and they already have antibodies, and it can lead to the second because they already have antibody and more severe.
Yes, that's the answer. Yes, correct. That's correct. Yes, very good. Yes, that's the answer. Because infants, in Vietnam, for example, infants about 4 to 9 months already have antibodies. But these antibodies have been produced by their mothers. Because their mothers, for sure, have been infected in their life. So these antibodies have crossed to the infants. So when the infants suffer the first disease, the primary infection, it's the first time, yes, but they already have antibodies. So the appearance is the same as if the disease is the second one, because they already have antibodies. This is the reason why infants between 4 to 9 months may suffer a severe disease, because they already have antibodies. But these antibodies have been produced by their mothers and have been transmitted to them. Do you understand why?
Yes.
Yes.
Okay, so that is the answer. And children 5 to 9 years, because this is the second time that they are infected in their life, usually, okay? They may suffer a severe disease. Okay, so don't forget, a second, this is the, maybe this is the most important of this slide. The second infection with a different serotype have a greater risk of severe disease. And this is clinical medicine, and I am not going to explain because I have no time. You will study in internal medicine. Currently, in the last 10 years, we can classify dengue into two groups. Dengue with or without warning signs and severe dengue. This is the new classification of the World Health Organization that appeared 10 years ago. However, in some hospitals, they still use the old classification from 1997, and they classify dengue into three groups: non-specific undifferentiated fever, classic dengue fever, or dengue hemorrhagic fever. You are going to see this dengue hemorrhagic fever in our hospitals till now. So we have two classifications, the old one and the new one. But this is clinical medicine, and I cannot explain because I have no time. Okay? So dengue with or without warning signs and severe dengue. Remember, the most important feature of severe dengue is plasma leakage. And the second one, hemostasis impairment. But this is clinical medicine for the future, not for microbiology. And in very few words, I show you this picture. And in this picture, this is also clinical medicine, I show you what happens when we are infected by dengue, okay? And we can classify the dengue disease into three periods. The first period, febrile period. The second one, the critical, the severe, the dangerous, and finally the recovery. I'm not going to say anything because I have no time, and this is clinical medicine. It's very sad, but I don't have time to explain this. Just to tell you that during the first period, fever may be very, very high, until 40 degrees. This first period depends, the damage in this first period mostly depends on the virus. Okay? The second period in red color, viremia disappears. So the damage in this second period mostly depends on the immune system. And this second period, the critical period, is the most dangerous. Fever disappears. However, the damage may be higher because of plasma leakage or because of hemostasis impairment. And you will study this in detail in clinical medicine, okay? Just remember that damage in both periods depends on the virus, the first one, on the immune system, and the immune system, the second one. So what is dengue? What do we feel when we suffer dengue? We have three periods. The first one, the second one, and the third one. During the first one, during the first period, we have very high fever, sometimes 40 degrees. For sure you know, because maybe most of you have suffered dengue. Fever, headache, and this headache is behind your eyes, so retro-orbital pain. Retro means behind, orbital means the orbits, the eyes. Severe muscle and joint pains. Some people call dengue like break bone fever. Many people show a rash in the trunk, and some people may show gastrointestinal symptoms, vomits or diarrhea. This is common in some people, so take care with this. Take care with this. Because maybe you have a patient with very high fever and diarrhea. Only that. But maybe the patient is suffering dengue. Okay? So take a lot of care with that. Every year when I teach this class, I explain to my students the case of one of my friends. When I was living in Vietnam 10 years ago, one of my friends, she was also a medical doctor, and one day she woke up with very high fever, 39, 40 degrees, and vomits and diarrhea, only that, for 2 or 3 days. So we thought that she was suffering a gastroenteritis with diarrhea. However, 5 days later, the fever disappeared, diarrhea disappeared, and she felt terrible. She felt very, very bad. She was very, very severe. So we went to the hospital, and the doctor said that she was suffering diarrhea. a gastroenteritis. However, they performed the test for dengue and she was suffering a very severe dengue. So take care with that, okay? I always remember this, always, and I will never forget. So some people may show gastrointestinal symptoms, okay? Anyway, about the laboratory findings, this is not microbiology, but I have to tell you. Thrombocytopenia is found in most patients. So low number of platelets. That's the meaning of thrombocytopenia. Low number of platelets. And elevated hematocrit, this is called hemoconcentration, is found in some patients severe. This is because of plasma leakage. But thrombocytopenia is the most common laboratory finding. How can we make the diagnosis of dengue? The diagnosis of dengue is made at the laboratory of microbiology. And we can detect three things. We can detect three things. I show you here. Diagnosis of dengue, microbiological diagnosis. We can detect antibodies against dengue, IgM or IgG. Remember, the first one that appears is always IgM. We can detect antigens of the virus, proteins, viral antigens. The most important antigen that we detect in dengue infection is the NS1 antigen. This antigen belongs to the dengue virus. And finally, we can detect the RNA, the nucleic acid, by using real-time reverse transcription PCR. So we can perform three things, okay? Antibodies, viral antigens, and nucleic acid. Look, remember, antibodies need a time to appear. So antibodies are usually negative in the beginning because they need a time to appear. So antibodies may appear after 5 to 7 days. Before 5 to 7 days, we don't detect antibodies. However, the antigen of the virus appears when the virus is replicating, so in the first days of the disease. So the antigen NS1 appears usually before 5 days. And the PCR, so the nucleic acid, the RNA, also appears in the beginning when the virus is replicating, obviously. So the RNA by PCR is also detected before 5 days. Okay? So if we have a patient with more than 5 days, with symptoms that last more than 5 days, antibodies will be positive. And maybe the RNA or the viral antigens are negative, okay? And the opposite is true for the others. I show you in a picture. Okay, so this is the day 5. This is the day 5 of illness. Antibodies become positive usually after the day 5, not before. The RNA of the virus and the NS1 antigen usually appear before the day 5, okay? We don't have any specific antiviral against dengue. We don't have. So the treatment of dengue infections is symptomatic. Fluid therapy is the most important. Remember the plasma leakage. The plasma is lost from the blood because the blood vessels are damaged. Remember plasma leakage. And something that I repeat every day, every year. Aspirin or other non-steroidal anti-inflammatory drugs are not recommended. This is clinical medicine, but I can tell you something, because these patients may suffer impairment of hemostasis. Remember, well, I don't know if you know this or not. I don't know if you have studied pharmacology or not. When you study pharmacology in the future, you will learn that aspirin and other non-steroidal anti-inflammatory drugs may interfere with the function of platelets, okay? So these drugs are not recommended to treat the fever. To treat the fever in these patients, paracetamol is indicated, okay? And how can we prevent dengue? the most important measures to prevent dengue is to avoid mosquitoes. This is the most important. In the last years, a lot of research is done to find a safe and effective vaccine. Currently, we have 3 candidates for vaccines. One of them, Dengvaxia, has been also licensed. It was licensed 5 years ago. And I remember this very well because at this time I was teaching in another university in Vietnam, and I remember. However, in these 5 years, this vaccine has shown that it's not perfect and has some failures that I am not going to explain because I have no time. In the book, I explain you everything in detail about this vaccine. If you want to know something else, you can ask me at the end of the class, okay? So currently we have 3 candidates of vaccines. Dengvaxia, that has been licensed already. The Takeda vaccine, this is from, I think this is Japan or Singapore, I'm not very sure. And this is in phase 3 clinical trials. The last data appeared in November, and it looks promising. And another one from the National Institutes of Health from the US. And this one also seems that it's good, but we don't know anything about them yet, okay? If we have time next year, we will have a seminar about vaccination against dengue, but now we don't have. Okay, any question about dengue before we continue? Dengue is very important, okay, in Vietnam. So hepatitis B and dengue are important classes here. Any question? Oh, you want to say something about dengue?
Các bạn có hỏi gì về virus dengue nữa không ạ?
Không ạ.
No.
No questions?
No.
Okay, so please, because I know that there is a lot of information, please study very well the microbiological diagnosis of dengue, okay? Study very well this. The tests that we can perform at the laboratory of microbiology before the day 5 and after the day 5. This is very important. This is microbiology. This is what we do in the laboratory. And please remember the most important features related with severe disease. Plasma leakage, the most important. This is one of the questions. And impairment of hemostasis. Remember this. And remember the immune response. Remember the antibody-dependent enhancement. Okay, this is the most important. Okay, so if we don't have any question, we can continue. And we are going to study a new topic: measles, mumps, and rubella. All of them together. These diseases are typical diseases of children, and this is a new topic that we didn't study last year because last year we didn't have time. And this year, we don't have time either, but we are going to perform a strong effort to explain you these diseases, okay? And we are going to study all together because we don't have time. Measles, mumps, and rubella are typical diseases of children, typical. Measles, this is the name of the disease, okay? Not the virus. Measles and mumps both belong to the family Paramyxoviridae that we have already studied. The family Paramyxoviridae contains parainfluenza viruses, respiratory syncytial virus, measles, mumps, and others. They belong to Paramyxoviridae. And rubella virus belongs to a new family that is called Togaviridae, okay? So, because we don't have time, and it's impossible to explain this in the class, we are going to focus only in very few things. So, we are going to explain in very simple words these 3 viruses, these 3 diseases using this table, okay? So, measles belong to the family Paramyxoviridae that you already know. Mumps also belongs to the family Paramyxoviridae. Rubella belongs to a new family, Togaviridae. The transmission of all of them is through the respiratory route, through droplets. All of them are transmitted through droplets, all of them. And the pathogenesis of all of them is different, but they have some things in common, okay? So we are going to explain only the things that they have in common about the pathogenesis. So exposure is through the respiratory route, through droplets. So in the beginning, the virus replicates in some cells of the upper respiratory tract. So local infection at the upper respiratory tract with replication in some cells. After that, they go to the lymph nodes. After that, they go to the blood. So this is called viremia. Remember, when we suffer viremia, we may show some non-specific symptoms like fever, headache, myalgia, fatigue, whatever. When the virus is in the blood, the virus is spread. And the virus will find the final target host cell, okay? And this final target host cell are different depending on the virus, okay? For example, the measles virus can infect many different host cells in the conjunctiva, in the respiratory tract, in the urinary tract, in the small blood vessels, in the central nervous systems. Many different host cells are infected by measles virus, okay? The same is also true for mumps virus, and the same is also true for rubella virus. So we are going to say only this, okay? So different viruses may infect different host cells that we are not going to study because we don't have time. So this pathogenesis is common for all. Patients with measles and with rubella, this is a typical disease of children, they may show a rash in the skin. Remember, the medical word for rash is exanthem. Okay? Both patients with measles and patients with rubella. In patients with measles, the rash is maculopapular. I explained this very clearly in the presentation, okay? Maculopapular. The exanthem in rubella is the same as measles, almost the same, okay? And this is new for you, maybe this is clinical medicine, but I have to explain you. The rash may appear in the skin, and that's called exanthem, but the rash may appear in mucosas, and that's called enanthem. This word, I think, is new for you. So enanthem is a rash in mucosas, for example, in the mouth, okay? Patients with children with measles may also show enanthem in the mouth. I will show you later. These are called Koplik spots. This is the typical enanthem in the mouth in children with measles. Children with rubella may also show enanthem in the mouth too, but different. This is called Forchheimer spots. Forchheimer spots. This is not microbiology, this is pediatrics. You will study next year, okay? So in microbiology, this is not important, just to show you. And patients with mumps do not show any rash in general, okay? So before we continue, what about the common findings? the clinical findings of patients with these 3 viruses. So I go back to the presentation. So look, we start with measles, okay? Measles is one of the classic children exanthems. They can infect many different host cells, as I told you before. Transmitted through droplets. And look, and don't forget this, measles is one of the most contagious of all infectious diseases. The transmission, the spread of measles virus is very easy. However, in the last 30 years, vaccination has reduced the incidence. All of you are vaccinated, so you will not suffer measles again. However, in the last 20 years, measles is increasing in some places because of different reasons. When I was a child, the vaccine didn't exist. So when I was a child, my friends and me and many others suffered measles because this was a very, very common childhood disease, but not you. Look, currently, we still have measles in the world. In general, measles is not a severe disease, but it can become complicated in some people, as I will tell you later. In young children, measles is still one of the most important causes of death, even when we have a good vaccine. So why is this possible? Because in some places, very poor, the vaccination programs do not exist. That's one of the reasons. So currently, unfortunately, more than 95% of deaths because of measles appear in poor countries. And this is a problem. Because the vaccine is very effective, and measles, if we are lucky, will be another disease that we eradicate from the earth. But we still need many, many years, maybe more than 20 years. So look, a child with measles. A child with measles is a child with very high fever, with cough, conjunctivitis, coryza. You understand coryza? Photophobia. So these are the most common findings in children with measles. So respiratory symptoms and symptoms in the eyes. High fever, cough, conjunctivitis, coryza, and photophobia. These are very common findings. And the most common finding is the rash, the exanthem, that I will show you later. The exanthem is maculopapular, non-pruritic, that means not itchy. It appears in the head and spreads later. Before the rash in the skin appears, before the exanthem appears, about 1 day earlier, the coplic spots, the enanthem, appears in the mouth. So look, this is the exanthem, okay? This is the typical child with measles. And this is the same, maculopapular rash. This is the enanthem, the coplic spots. The coplic spots appear in the mouth and they are white. The coplic spots are white. Some people say that they look like grains of salt surrounded by a red halo. This is the description of coplic spots. Like this. They are white and they appear in the mouth. This is the enanthem, the coplic spots appear earlier than the exanthem, okay? Again, this is not microbiology, but I think we have to spend some minutes explaining this, okay? We don't have any antiviral therapy against measles, nothing. But we know that vitamin A is effective for the treatment of children. They can recover earlier and we prevent the complications. Because measles may become very severe in some people. the most severe complication is superinfection, bacterial superinfection. Because the immune response may be impaired. Measles may impair the immune response. So this is the most common and the most severe complication, bacterial superinfection. So these children may become infected by a bacteria after measles. Other children may suffer central nervous system infections. That's possible. Or diarrhea, or many others, okay? Many complications are possible, but bacterial superinfection is the most common. And that is the only one that you have to remember. And currently, as I told you before, we have a vaccine. This vaccine is a live attenuated vaccine. And this vaccine, the MMR vaccine, contains antigens to protect against the 3 diseases: measles, mumps, and rubella, hence the name MMR. We give this vaccine in 2 doses, okay? The first one between 12 to 15 months of age, and the immunity is possibly forever, okay? The current vaccine. However, maybe you find some cases of measles now in adults, not in children. In adults around 40 years old, because the first vaccines that we received when I was a child were different and they were not very good. So currently we can find some cases of adults around 30, 40 years old because the vaccines were different, okay? So we are going to write in the table here the prevention is for the 3 diseases by the MMR vaccine. And this vaccine is a live vaccine, live attenuated, given into 2 doses. The treatment is symptomatic, so the fever, for example, and in children with measles, we can give vitamin A. And I show you here fetal infection, if transplacental transmission is possible. And yes, transplacental transmission is possible, but fetal infection, fetal disease is not important. So we are going to say no, okay? The only one important is rubella, but I will tell you later, okay? So we are not going to say anything else about measles. This is a pediatric disease that you will study in deep detail in pediatrics, okay? What about mumps? What should we know about mumps? This is another disease of children, another. I was infected when I was 2 years old. I remember perfectly. And the transmission is also through droplets. Before vaccines were available, so when I was a child, almost all people were infected. 90% of people were infected before 15 years. So we go to the table. The most common finding in children infected with mumps is parotitis. Sorry, parotitis. So this is inflammation of the parotid gland. The most common and the most important. And fever. These children also have fever. Fever and parotitis, because all of these children have fever. Wait a moment. Because someone has entered now. Wait a moment. Okay, so parotitis is the most common finding. And the most common complication is orchitis. Mumps virus is a virus that can infect many different host cells, and these host cells are usually found in the glands. The most commonly infected gland is the parotid gland, but not the only one, the parotid. And sometimes the testes may be also infected. And this usually happens in adults, not in children. And this is important. This is a very important complication in adults infected with mumps, because sometimes, this is not common, but sometimes, rarely, they become sterile. So infertile. This is the most important complication, okay, orchitis. But not the only one. Encephalitis or infection of the pancreas, there are many complications, but that's the most important. So, what is parotitis? Parotitis is an inflammation of the parotid gland. This. The parotid gland is found here. Sometimes the submandibular glands may be also inflamed, okay? This is the typical appearance of a child with parotitis. Typical. Inflammation of the parotid gland. The most important complication is orchitis, and this happens in adults, not in children, okay? And this problem, this orchitis, inflammation of the testes, may cause sterility, but this is not common, okay? We don't have any antiviral treatment, only symptomatic, and the prevention is also through the MMR vaccine. These are the only things that we are going to say, okay? So parotitis, this is the most important, and this is the most important. And fetal infection, no, it's not important. And the treatment is only symptomatic. And finally, we are going to talk a little bit about rubella. Rubella means in Latin language, little red. Rub in Latin language means red color. And ella means small, very little. Anyway, rubella virus belongs to a new family, the family Togaviridae. They are very similar to Flaviviridae, so we are not going to say anything about them. They have single-stranded RNA, positive sense, the same as Flaviviridae, with icosahedral capsid, the same as Flaviviridae, and envelope, the same as Flaviviridae. And the envelope contains different proteins. Some of these proteins, this one, are used by the virus for binding host cell receptors. But we are not going to explain anything in detail, okay? So, what is rubella? Rubella is another typical children exanthem. Typical. So, what is rubella? What is rubella? Rubella is very mild. Not measles. Measles are not mild. The child looks very sick for about 1 week. Not rubella. The common findings of rubella are very similar to measles, very similar, but milder. Milder and shorter. This is the typical rubella that appears in children. We are going to say postnatal rubella. I will explain you later why. Postnatal. Postnatal means after birth, okay? Post means after, and natal means birth, after birth. So the typical postnatal rubella is very similar to measles, but milder and shorter. What's the problem of rubella? Rubella is very mild. The problem of rubella is that transplacental transmission is possible and fetal infection is possible and severe. Fetal infection is severe or very severe. This is the problem. And this is called congenital rubella syndrome. Congenital rubella syndrome. And this is very severe because Rubella virus is teratogenic. Do you understand the word teratogenic? Genic means to cause, and teratos in Greek language means defect. Teratogenic means that they can cause malformations, defects in the fetus. So if you are a pregnant woman and you become infected by rubella, nothing will happen with you because rubella is very mild. However, you can transmit the disease to your fetus, and the fetus may suffer a very severe disease, the congenital rubella syndrome. The fetus, the newborn, will have severe, important malformations. For example, deafness is very common. The same as cytomegalovirus. Or microcephaly. This is terrible. Microcephaly. Cephaly means head, micro means very small. And many others that I will show you now. So the problem of rubella is the congenital rubella syndrome. Don't forget this. The most important clinical problem is the infection of the fetus. So before we had the vaccines, many children were infected. The problem before vaccination was that many young women were not infected during childhood, so they were susceptible. So if they were pregnant, they had to take care not becoming infected with rubella. I don't know in Vietnam, but in my country, women around my age, 30, 40 years, they were not vaccinated. So they have a high risk of becoming infected as adults. One of my friends in Vietnam, she is 45 years old, and she was not infected. She was tested, and she was susceptible. So she was vaccinated. I think all of you are vaccinated already, because the vaccine against this virus appeared many years ago. Oh, right? That's true? No? Because when I was teaching in another university in Vietnam, in the south, we had a vaccination campaign for the students because they were not vaccinated. So I don't know here if you are vaccinated or not. You know? I don't know.
Yes, I have been vaccinated with rubella.
Sorry? Not rubella. Okay. So the small children now, yes, but not the students, maybe. Okay, so for you women, maybe you are not vaccinated against rubella. Maybe you are vaccinated against measles, but not against rubella. So if you're a woman, you have to take care with that, okay? Maybe you have to test. Because I remember my friend, and she was not, she was susceptible, okay? So small children now are already vaccinated, but you, maybe not all of you, maybe only some. I was not vaccinated. So currently, is why I tell you, unfortunately, currently rubella is still a very serious problem in some places, okay? In Southeast Asia, so here, we have more than 45,000 cases of congenital rubella syndrome every year. This is the problem that we have now. And children are born with severe malformations. That's the problem, okay? So what's rubella? In children, nothing. In children, is, as I told you, is very similar to measles, but milder and shorter. The rash is very similar to measles, very, very similar, and the spread is similar. Patients with rubella also have enanthem, and the enanthem is called Forchheimer spots that I will show you later, okay? So we write here. So the rash, the exanthem, is similar to measles, and the enanthem also appears in the mouth as Forchheimer spots. And something typical that appears in children with rubella is lymphadenopathy. So swollen lymph nodes, usually behind the neck, so occipital, and retro means back, retroauricular, so behind the ears. Retro means back, auricular means ears, so behind the ears. This is very typical. I show you the pictures now. This is typical of rubella. So wait. So look, this is the exanthem in the skin, very, very similar to measles. This is the enanthem. These are the Forchheimer spots that appear in the palate. And this, in this area here, behind the ear and behind the neck, these are the ears where we can find the swollen lymph nodes, the lymphadenopathy. That's very typical of rubella. But this is not microbiology. This is pediatrics, and you will study in detail in the next years. The problem of rubella is not this. The problem of rubella is the fetus. Because the fetus may have many permanent defects. For example, as I told you, deafness. Cataract. This is very severe. I will show you the picture now. Or congenital heart disease. Or microcephaly, so a small head. Or mental retardation. So look, many different malformations are permanent and may appear in children infected with congenital rubella syndrome. This is the cataract. You understand cataract, right? In the eyes. The crystalline is opaque. Cataract. And this is microcephaly. This is a child with microcephaly. Many different congenital viruses may cause microcephaly. Maybe the most common is rubella. But if you remember the epidemic 5 years ago, the epidemic of Zika virus, many children with congenital Zika virus infection 5 years ago were born with microcephaly, and that was terrible. Mostly in South America, to my knowledge. I don't know in Asia, I forgot. But in South America, in Brazil, we have many cases of microcephaly because of congenital Zika disease. We don't have any antiviral treatment. The treatment of rubella is only symptomatic. The most important thing that you have to remember about rubella is the congenital rubella syndrome. This is the most important thing that you have to remember. So the treatment is symptomatic. And the prevention is with the same vaccine. And I think, wait a minute, I think we can finish the class. Yes, well, I want to remind you something of the vaccine. Self-learning topic 4. We explain the vaccines. This vaccine, MMR, is live attenuated. So remember, live attenuated vaccines cannot be given to pregnant women and immunocompromised people. So pregnant women should not receive the vaccine. So if you are susceptible to rubella, you must be vaccinated before you are pregnant, okay? And pregnancy should be avoided for 28 days after vaccination. So if you are a woman and you want to be vaccinated, you have to wait 1 month before you get pregnant, okay? Because this is a live attenuated vaccine. Not recommended for pregnant women, not recommended for immunocompromised people. Questions about the class today?
No.
Questions? You want to say something? The exanthems in children are a lot. And this is the study of the exanthems in children is very important in pediatrics. You will study next year or in 2 years. Many different diseases may cause exanthems, many different. I'm not sure if it's in this class where I show you all the viral exanthems of children. No, it's not this class, but in another class, if you check the complements for better understanding, I show you the 6 typical exanthems of children. 6 typical. Okay. Measles, rubella, scarlet fever. What else? A lot. I don't remember now, but there are so many. Okay, and you will study next. Yes, roseoloviroses. A lot. So when you study pediatrics in 2 or 3 years and you go to the hospital, every day you are going to meet children with exanthems. Every day, I promise. Okay, so the exanthem in children is very, very common, very common. You are going to meet many children. And most times you will have no idea why. Okay, so don't worry about that, because most exanthems are very mild. Except one, petechiae. So I hope that in these 2 days you have checked the clinical case that I asked you, okay, to the class R, and you have found why, okay? But if I have time this afternoon, I will send you the feedback about the clinical cases, okay? That was the most important. Anyway, so if we don't have any question, we are going to finish the class. Any question?
About the transmission of the dengue virus.
Yes.
You showed in the slide that inflammatory, permanent inflammatory in the salivary gland, right?
Yes.
Then how is the mosquitoes usually suck our blood? Then how come
Yes.
the virus in the salivary gland?
Yes, yes. Because the mosquito regurgitates the blood. So the word in English is regurgitation. I write for you here. It's not a vomit. It's not like vomit. No, it's not so disgusting. Regurgitation means that when the mosquito is feeding the blood, sometimes the mosquito regurgitates. I don't know how to translate this. So
it's like pumping something into our
exactly.
cells?
Yes, pumping back. That is regurgitation. Okay?
Yes.
But you can translate this into Vietnamese from English and you will find the right meaning. But it's something like that, yes. The same, for example, have the same problem, or not the same, but very similar, also happens with plague. Yersinia pestis. The rat, okay, when the rat bites the human, a regurgitation also appears. Okay? It's very similar. More questions? Question?
If the mother have suffer rubella and
yes.
And develop the antibody,
yes.
So will the infant, the children need any vaccine against rubella at all?
If the pregnant, so you mean, sorry.
Yeah.
If the pregnant woman has suffered rubella.
Yeah, before
pregnancy. Before pregnancy.
Yes.
If the mother suffered rubella before pregnancy, the mother is protected. So the mother will not transmit the disease to the fetus. The baby will be vaccinated when the baby is born at 12 to 15 months, okay? But no problem. If the pregnant woman, if the woman was infected before pregnancy, there's no problem.
Oh, but if the woman develop antibody against rubella?
Yes, what happens?
So does it transport to the infant, the antibody?
Yes, the antibodies, IgG, enter into the infant, yes. But remember that if these antibodies from the mother only protect the infant for very few months. After that, they disappear. That is the reason why we have to vaccinate the child.
Okay, thank you.
Antibodies from the mother, so they are usually, transmitted through the placenta, are usually IgG. And through breastfeeding, through lactancy, is IgA and also IgG. And these antibodies protect the child, yes, but for very few months. These antibodies disappear later. So that is the reason why children are protected for the first months of their life, but not later. So we vaccinate the child 12 to 15 months later. Okay. Questions? No questions?
No.
Teacher.
Yes.
So because the IgG just appear a few months, so with the dengue virus, just about the infant, they have the high risk of the severe disease.
Sorry, can you repeat again, please?
So the antibody of the mother will transport to the infants.
Yes.
So the infants will have the high risk of the dengue virus.
The infants have high risk of severe dengue in the first month.
Yes, severe.
Yes, only in the first month.
Okay.
Until they disappear, because the same reason. These antibodies are IgG. So after 6-7 months, these antibodies will disappear because these antibodies come from the mother. Antibodies from the mother disappear after 6-7 months. So that is the reason why if children become infected before these 6 months, they have a high risk of developing severe dengue. But after 6 months, these antibodies do not exist anymore. So after 6 months, the infants do not have risk of suffering severe disease, only in the first months of their life when they have antibodies. You understand what I mean?
Yes, thank you.
Because antibodies from the mother, IgG, only last for a few months. After that, they disappear. More questions? No? Okay, so we finish the meeting and we will have another class tomorrow in the morning, okay? The lesson 16 about yellow fever and viral encephalitis. That is very, very important. Some of them are very important in Vietnam, as you will see. Okay, so see you tomorrow.
Bye.
Goodbye. Take care and good luck.